Hello, everyone. It gives me great pleasure to be joining you online to give my talk today on the impact of the COVID pandemic on maternal and newborn health. I'm Shakila Thangaratinam. I'm a professor of maternal and perinatal health based at the WHO Collaborating Center at University of Birmingham in UK. I'm also a consultant obstetrician who is based at the Birmingham Women's and Children's NHS Trust. So if you look at the effects of COVID-19, it has got an impact right from the diagnosis of pregnancy to early pregnancy, in late pregnancy, childbirth, and afterwards. And it has an impact both on the health of the mother and her baby. Let's look at the direct effects of the pandemic. These could either be COVID-19 related complications in the mother and in the baby, or it could be pregnancy related complications that occurs in the mother because of the diagnosis of COVID-19. There are also hidden impact of the COVID-19. These are the indirect effects of COVID-19, and these could arise from a variety of causes. Limited access to healthcare services is a biggest concern, both for the parents as well as healthcare providers across the world. The pandemic necessitates changes in protocols, be they relate to the type of clinical care provided, the tests that are performed, and the support network that a mother can access. The environmental restraints. Many of us continue to be in lockdowns in many countries, which has an impact on both access to care as well as availability of the antenatal care visits to the mother. The economy is a huge concern, which directly has an impact, particularly where there's a huge healthcare provider set up in the country. And last but not the least, the changes in the social fabric. With social distancing and restrictions, women don't have access to the support network that they would usually be exposed to during pregnancy as well as in caring for her newborn. So today, for my talk, I would like to focus first and predominantly on the direct impact of the pandemic. I'll also, towards the end of my talk, give a brief overview on some of the evidence emerging on the indirect effects. So when the pandemic first came into light, there remained a lot of questions that were unanswered, and healthcare professionals, understandably, particularly obstetricians and midwives, were quite concerned about the health of pregnant women and their babies, given our past experiences with SARS and MERS viruses. We wanted to know the clinical manifestations of COVID-19 on pregnant women. And what about the rates of outcomes? Are there any specific risk factors that predispose certain women and their babies to complications than others? And what about the effective treatment options? Are those treatments that are beneficial in a non-pregnant population also be offered to pregnant women? And finally, what is the risk of transmission to the baby from the mother? So to answer these questions, here at the WHO Collaborating Center, University of Birmingham, we established a living systematic review to answer the above questions. It's called a living systematic review because, unlike traditional systematic reviews where we do a review and publish it, this is a review in which we constantly update the evidence on the regular basis as new evidence emerges. And we will look shortly in how we do it and what our findings are to date. So this is an overview of the type of work that we do for living systematic reviews. Now, as you can see, we first registered a protocol in Prospero, and then we do searches. These are done on a weekly basis. And then there are teams of individuals, a lot of the medical students who are involved in the selection of the potentially eligible studies. And once we've identified those studies that have the evidence, then our teams start work on extracting the data. We do analysis and regularly update our findings. And that's just for one round. And then the process continues for searches for the second round. I mean, Magnus is one of our medical students, and you would notice in my talk that there might be pictures of the various collaborators who have actually contributed to this presentation. So where are we with our findings? I mean, the findings were published in the BMJ very recently. That's the findings for the first round of searches. And we identified 77 studies with over 13,000 pregnant and recently pregnant women with COVID-19, answering all of the questions that I briefly mentioned before. Why do we need a living systematic review? This just shows the rapidity in which evidence keeps updated. We first submitted to the journal with 34 studies. And then by the time we got the peer reviewers' comments, we revised the submission, there were 77 studies already out there. And once we've submitted, by the time the paper came out, there were 86 studies. It just shows the rapid turnover and the need for a living systematic review. So what did we find with regards to the prevalence of COVID-19? And we found, if it looked for those hospitals that were doing an universal screening, it's about 7% is the risk of COVID-19 being diagnosed in those women who are admitted in the hospitals for any reason. And symptom-based screening, of course, the number is a bit slightly higher at 18%. But overall, it seems to be about 1 in 10 women who are in the hospital for any reason are diagnosed with COVID-19. And this number seems to be pretty stable because we recently updated for our next round, and we continue to have the same figure of 10%, irrespective of the country and the time duration. So of those 11,000, about 1 in 10 is the prevalence we're looking at. And if you look at asymptomatic pregnant women, about 5% of them seem to be diagnosed with COVID-19. And again, it highlights the possibility of having COVID-19 despite having no symptoms in this group. How about the clinical presentation of the disease in pregnant and recently pregnant women? So this was our last update based on the search until the September. So there were about 26,000 pregnant women from 23 countries contributing data, of whom, if you look at the 50 studies with the relevant data on symptoms, about 40 to 45% seem to be presenting with fever and cough. That seemed to be the commonest symptom in pregnancy, followed by 20% with breathlessness and muscle ache. If you look at the laboratory findings, lymphopenia and raised white cell count seem to be the commonest symptoms. And we recently also identified increased C-reactive protein also to be one of the commonest abnormal lab markers. And in 25 studies who did imaging of some sort, about 63% did have consolidation. So overall, the type of presentation, I mean, like the common symptoms of cough and fever seem to be very similar in pregnant populations, similar to the non-pregnant one. Although we did find that the proportion of women who present with symptoms are far less in pregnancy compared to those of non-pregnant women of reproductive age. So what about the maternal outcomes? So of the 94 cohort studies that provided this data, 73 give information on COVID-related outcomes. About 4% of pregnant and recently pregnant women have been admitted to the intensive care unit. About 3% appear to need invasive ventilation. And overall, the rate of severe COVID appears to be 1 in 10 pregnant women who've been diagnosed with the disease. And the mortality is 6 per thousand. How about comparing these outcomes in pregnant women compared to reproductive aged non-pregnant women? So we're not talking about older individuals or in reproductive aged non-pregnant women. So our first round of findings did show that the risk of admission to the intensive care unit and the need for invasive ventilation appeared to be higher in pregnant women than those who are not pregnant. And in the recent update, in fact, we've also found the same findings, but additionally found an increased risk in the need for ECMO, as well as a risk of maternal death. So the evidence that seems to be emerging is that pregnant women are higher risk of having severe COVID-related complications, both morbidity and mortality, compared to non-pregnant women. What about the risk factors for severe COVID in pregnancy? So what are the variables we need to be looking for? We found that women who enter pregnancy with pre-existing conditions like chronic hypertension and pre-existing diabetes seem to be at higher risk of having severe COVID than women without those risk factors. And this seems to be very similar to that of the general population. And in our recent update that will be coming out soon, this increased risk seemed to be consistently observed in the subgroups I've just shown. Additionally, we've also observed an increased risk both in women with any comorbidity as well as those with gestational diabetes and preeclampsia. So all of these seem to be risks, predisposing factors for severe COVID. What are the other factors? So increasing age appears to be a risk factor. High body mass index, yes. And in the recent update, women of non-Caucasian origin seem to be at higher risk. We have not observed an increased risk in women who are diagnosed in the third trimester compared to those who are diagnosed in earlier trimesters. Having said that, I should also like to point out that most of the women in these studies were in the hospital in the third trimester, and we are yet to follow up those women in the earlier trimesters to be able to provide these results with increased confidence. But definitely age, body mass index, and ethnicity seem to be risk factors for severe COVID in pregnancy. And how about the pregnancy outcomes? So the rate of preterm birth seemed to be around 2 in 10 and around 6 in 10 with the rate of cesarean sections. Having said that, although the 20% preterm birth seems to be high, risk of spontaneous preterm birth is still 7%, which highlights the fact that there is an increased degree of iatrogenic prematurity that possibly is behind the increase in the rates of preterm birth. How about when we compare the pregnancy-related outcomes in pregnant women who are diagnosed with COVID compared to those who don't have COVID? So yes, the rates of preterm birth appear to be high, but again, we need to rule out the role that iatrogenic prematurity plays. And cesarean section, that does not seem to be an increased risk in those with COVID. And in our recent update, we also found an increased risk of death in pregnant women with COVID and possibly of stillbirth. However, I should say that the numbers are still small, and we would like to have further updates before we provide in with higher confidence in our estimates. The risk of admission to the neonatal unit is also high, but these could be due to a variety of factors, not necessarily because the baby is sick. It could be that in order to, initially when the pandemic broke out, there were huge concerns about mother-to-child transmission. A lot of these babies were kept apart from the mom. So it could be for various reasons and not necessarily purely from the disease itself in either the mother or the baby. In fact, it could be an indirect effect of the pandemic. And how about mother-to-child transmission? There are concerns that it could be transmitted intrauterine during labor and delivery from exposure to vaginal fluids or fecal matter, and also a risk of transmission during breastfeeding. The challenge is there has not been a consistent definition on what is definitive mother-to-child transmission. And is there really an infection? Would a PCR in the baby, the one test alone is unlikely to be an infection? So until we are able to standardize and have an agreement on the definitions of mother-to-child transmission and what actually would count as infection in the newborn, we currently are only looking at the rate of positivity, but hopefully by the time we publish our findings, we will be able to match as whether it's a definitive mother-to-child transmission or a possible, probable, unlikely. So far, based on our current estimates, around 8.5% of those newborns who are born to mothers with COVID seem to have at least one test that's positive for COVID, which does not necessarily mean that the baby is infected. However, none of the evidence actually attributes any transmission through breast milk at the moment, and the risk of having COVID-19 does not appear to be significantly high through vaginal delivery. So based on current evidence, vaginal births and breastfeeding are welcomed and not contraindicated in pregnant women with COVID. So moving on to the indirect effects of COVID. So this was a paper that came out pretty early on in the pandemic. In fact, a preprint came out first before the publication of the full paper in Lancet Global Health. And the authors modeled the impact of the pandemic according to how severely the services would be hit. So they had three scenarios. Scenario one had the least impact, around 18 to 20% hit in access to antenatal care as well as intrapartum care. And scenario two is where there was a 25% affected services. And scenario three was half the services were affected, those providing antenatal and intrapartum care. And it shows a worrying trend in the increase. This is on maternal deaths, the table that you can see. It shows that as the access reduces, when you have a 50% out of access, there's a relative increase of up to 38% increase in maternal deaths. So the additional deaths per month, where the scenario is quite optimistic, is 2,000 maternal deaths as additional deaths. And by 12 months, there are 24,000 maternal deaths. And after the study on modeling, the recent paper on stillbirth, neonatal and mortality outcomes in Nepal does show that compared to the pre-pandemic data, the data during the pandemic shows us an increase in the risk of preterm birth by 1.3-fold after adjusting for various underlying risk factors. The risk of stillbirth appeared to be increased, and so did neonatal mortality rate. And these are worrying data, and we do need more information from different institutions and countries to have a grasp on the burden of the pandemic. Not necessarily a direct threat, but also an indirect threat, but nevertheless a huge threat to mortality and morbidity of women and their babies. And in the Nepal data, it showed that breastfeeding initiation within an hour reduced by 3.5% during the pandemic, and intrapartum fetal heart monitoring was affected by 13%. And these are stillbirths and neonatal deaths. We don't know the long-term severe morbidity that mothers and their newborns will be encountering because of the pandemic. The other major impact of COVID is the mental health of mothers and on fathers. Uh, Often fathers are not part of the visits that they would usually be expected to accompany, such as for the ultrasound visits, with not all hospitals or all countries provide the opportunity for dads to accompany. And the recent paper looking at the health anxiety and behavioral changes showed that 50% of women who are pregnant during the pandemic worry about their health often or all the time. That's 1 in 2 are really concerned about it. And well, over 60% do worry about the unborn baby. And this is on top of all of the other anxieties they have. They have anxieties about their jobs, they have anxieties about their current children, about their elderly relatives. So this is purely health anxiety alone, and it is going to have a cumulative impact when this combined with everything else that's happening in their lives. So we also know that its increased risk of clinical depression and anxiety seems to be 1.94 times significantly increased during the pandemic than the pre-pandemic level. And more needs to be done to study the impact on the dads. But also, let's not forget the impact of COVID on healthcare professionals' mental health. And that's a key area in their, could be affected because of concerns to themselves from being exposure or concerns on spreading the infection to their families with vulnerable members by being in contact with the women or their partners with COVID. Concerns that they're not able to provide the type of care they would like to provide, or that sort of close interaction that they would like to have, which has been restricted to a certain extent because of the pandemic. And it is quite an important area that needs to be studied further in addition to the physical impact of the pandemic. So before I finish, I want to sort of highlight the collaborative network that we put together to do this work. And this is the first time we actually relied a lot on a new cadre of individuals, the medical students, who usually or those whom we teach and less as our colleagues. But the pandemic placed us in a significantly different setup where our clinical academics, a lot of them have to go back to the front to look after women, and researchers could not come to the institutions, and the medical students were available. So as you can see, in the first wave of the pandemic, we trained 4 medical students, who then in the second wave, we had 4 others, and gradually they increased in number. And it's a really good model for us to know that we can rely on these young future researchers and future clinicians, and with the proper support, that they are able to undertake high quality work. And also we have got collaborators globally, including from Centers of Disease Control in the US, the European CDC, our collaborators from China, in addition to our collaborators at the World Health Organization. From India, we have Dr. Umaram and Dr. Ajit, who have been providing the perspective on interpretation of our findings, and hopefully to integrate more of the data coming from India in the future updates of our systematic review. So these are the links for you to go, and you can access the information. So we do tend to update our evidence every 6 to 8 weeks. So please go into the website and feel free to access. We did run a series of 4 webinars on COVID-19 in pregnancy, from mental health, from respiratory care, newborn care, both from low and middle income country perspective, but also from the perspective of healthcare professionals and women. So we had women who came in and shared their experiences. So again, please, if you are able to, feel free to access the webinar series. And that's my Twitter account, and details to know more about your work below. Thank you very much. Take care.